Hey there, hello, welcome. I'm really excited to join you live tonight. I asked you all what you wanted to hear about because I've been diving into a lot of different papers on many different topics, and you all voted, so thank you. And the top topic was on functional neurologic disorders and treatment complexity. So here we are. We're going to talk about it. I'm going to incorporate some of the recent literature that I've been reading and start off with our pie chart. So I'm going to bring this up here. And please, in the comments, if you have questions, throw them my way. You all also sent me a bunch of questions, which were really helpful. And I will be going through and answering questions. So I want to start here, which, by the way, if we haven't met, my name is Julie Hirschberg, and I'm a neurologic physical therapist. I run a clinic. It has 2 locations in the Los Angeles area. We work with people from all over the world with different neurologic disorders. Functional neurologic disorders, a big one, and I'm hosting, myself and my colleague Brittany Kim, we're hosting a live workshop for therapists, and it's next week. So this is why I'm diving into the literature. We do workshops on FND a couple of times a year for clinicians so that they can grow in their knowledge and skills with it. And we update it all of the time. So this one is brand new. If you're a clinician, come to it. It's next week. It's Tuesday and Thursday. There's 2 options for you. So it's next week, the 19th and 21st of September. You can sign up at reactiveeducation.com. Anyhow, let's dive into some of the complexities of treatment, because I have found that even we have some clinical practice. It's not a guideline. It's a resource that has been published in FND. It's really great. I recommend it for people when they're getting started, but it's missing some of the big pieces. Like if you just looked at somebody's motor control and tried to use distraction or external focus, if you look at this pie chart, you're missing 90% of what's going on. If you just looked at the sensory system, you're missing big pieces. If you just looked at autonomic, you're missing big pieces. Even if you just looked at those 3, there's a whole nother half of the pie chart. The lifestyle pieces, psychosocial pieces. And one of the complexities that I want to talk about today is their physical limitations. And this is so, so important. So yes, you could try to simplify FND into sensory motor changes and autonomic issues. But again, you're missing big chunks of FND treatment. It's complex. However, we have actually simplified it into a pie chart that then you can take as a clinician, you can take and really by listening to the patient, doing a very thorough assessment, you can get down to and simplify some of those complexities so that you can understand how big is that motor control piece of the pie? How big is the autonomic piece of the pie? And individualize your treatment, because some folk with FND, those aren't the biggest pieces of the pie. It's actually that they have a hypermobility disorder, and that's really contributing to impaired joint proprioception, and so there's a sensory component. They have pain, and that's a sensory and physical limitation component. It's greatly affected their lifestyle and their activities that they can do, and so they're no longer engaged in purposeful activities, so that's a lifestyle component. And so if that's contributing to a functional neurologic disorder, if you missed that physical limitation, you missed probably the biggest piece of the pie. So I have shared before, and I'm going to share it again, this particular article here. There's a couple of articles that look at hypermobility in functional neurologic disorders. And it's something clinically that we see a lot, whether it's diagnosed before or it's something that we screen for. We don't give the diagnosis, but we can certainly treat it. And I'm really happy to see that it's in the literature. So I shared this article before. I've got it here with me too. Korecki, I think maybe is how you say that name, the last name, Hypermobility in Patients with Functional Seizures Toward a Pathobiological Understanding of Complex Conditions. So it is a complex condition. FND is complex, hypermobility is complex, the intersection of the two is complex. I do want to say hypermobility is not a functional neurologic disorder. That is not the case. It is its own entity, but it is something that we see coexisting with functional neurologic disorders frequently. And that's what they found in this study as well. And what they propose in the discussion in thinking about this like physiological or pathophysiological piece, they propose that the differences in hypermobility disorders. So we get differences in autonomic control, interoception because of the hypermobility, even in brain structure, and then of course the actual changes in sensory information coming from the joints due to joint proprioception. This may predispose people. Now they're looking at functional seizures, but I would say functional neurologic disorders in general, it may predispose people to a functional neurologic disorder. And that is an important piece then to screen for and treat. So I want to pull this picture up. I've shared it before as well. But this diagnosis pie chart. So when we see people with functional neurologic disorders, it's very rare that is all they have. When we're talking to them, we often hear things like migraine. We do hear that they might have a hypermobility disorder like Ehlers-Danlos syndrome. They might have dysautonomia like postural orthostatic tachycardic syndrome. And they have an FND. Those things are not FND. Migraine is not. Hypermobility is not. POTS is not. But all of those things can contribute. And then so we want to zoom out and look at all of those diagnoses. This takes really careful neurologic examination. And then I'm going to go back to our other pie chart. The beauty of the pie chart and this framework for assessing and treating complex conditions is that there are overlaps of those diagnoses that we can assess and treat, and they might be the hypermobility might be underlying the FND. The autonomic dysautonomia or POTS might be underlying the FND, meaning it's part of a contributing factor. We can treat both, right? So we can treat the all of the pieces. So we might treat the FND, the EDS, the hypermobility, the migraine, because they all have autonomic components, right? So if we treat in the autonomic nervous system, we can actually treat all of those pieces together. They all have sensory components. So if we treat the sensory impairment that we see and test, then we can treat all of them at the same time. And one of the things that I really want to caution against when it comes to FND treatment complexity is to not chase symptoms. So one of the things that we can frequently see happen is that a person might have weakness, and it might be variable, might change limbs. They might have sensory changes, then that might also be variable. They might have seizures, and those are variable. What is so important in functional neurologic disorders, and especially because of these comorbid conditions, is to actually get to the bottom of why. Why is that person having tremor? Is it actually because they're orthostatic or tachycardic? Well, let's treat that. Why is the person maybe experiencing functional paralysis? Is it because they have a hypermobility disorder and they're getting incorrect proprioceptive information and therefore their muscles are not firing? Well, let's treat and support their joints and their muscular system so they get the correct sensory information. So are you following me here? So instead of chasing symptoms in functional neurologic disorder, we want to get down to what is underlying that. And these coexisting conditions like hypermobility, like dysautonomia, migraine, for example, they may be part of the underlying issue that is contributing, and they need to be treated. They absolutely need to be treated. And again, if you just focused on one piece of the pie, or even 3 pieces of the pie, if you just focus, but my favorite pieces, motor, sensory, autonomic, love them, but if that's all you focused on, you would and the person had hypermobility, you would absolutely miss a physical limitation by not treating it. So that is one of the treatment complexities. But again, having a framework like this pie chart, this is what we're going to talk about in our workshop. If you're a clinician, come next week. We're going to talk about the pie chart framework. We use this framework, we teach this framework, we do this framework with all of our patients because it doesn't just chase symptoms, it actually helps us understand what's underlying those pieces. Now, I want to share another article here, which I found really interesting. I'm not totally sure I agree. I just felt it was interesting. This one came out in the Movement Disorders Journal. Hypermobile Ehlers-Danlos syndrome, a prodromal subtype of functional movement disorders, with the question mark. It's not saying it is. This is a really small study, as most of these studies are, by the way. Not a lot of patients. I want to say it was 16. I had the article right here in front of me, but I also have a lot of articles right here in front of me. Here it is. They looked at, it was 16 patients. So 16 patients with hypermobility disorders, Ehlers-Danlos syndrome, and then 9 of those, so over half, were also diagnosed with FND. What they found, and this is why the question mark is this prodromal? What they found is that for the most part, people were diagnosed with EDS before they were diagnosed with FND. So what they were wondering is this prodromal. Now, my clinical experience is not that it's prodromal. And so I'm not saying necessarily that I disagree. They were asking a question, is it prodromal? My clinical experience is that these things just come alongside of each other, and perhaps the hypermobile EDS is actually a predisposing factor because of, there's many pieces associated with EDS, but I think one of the biggest pieces that I see is related to a joint proprioception. And so our brain is not getting the correct information about the body. And we know in the predictive brain model and how it predicts movement, if we don't get that correct feedback, we actually don't get the error message about our movement. So I'm going to just go up. I saw a couple of questions. Thank you so somebody was just repeating my soapbox here about don't chase symptoms. Ask the questions why. Why are they having tremors? Why are they not getting sensory information? Both questions are so good. Thank you. Yes, this is why we need to dig deeper in FND. And also not assume. Because I love differential diagnosis, but when anybody I meet or we're working with them and has been diagnosed with FND, I'm constantly digging, like, is there something else there? What else is contributing to this? And if you look at even this article, by the way, I should have taken a picture. They had a table with all 16 patients, and you can see in this table, the person might have had functional tics, but they had EDS. They also had fibromyalgia, migraine, depression, anxiety, insomnia, POTS, and a Chiari-1 malformation. This is very common, is what I'm going to say. Having multiple comorbid conditions is very common in FND. That is why we can't overly simplify. I love to make things simple. I love to provide a framework, but we cannot overly simplify FND. There was another question here. Have you ever heard of FND developing suddenly after a traumatic hospitalization with extreme allergic reactions? What a great question. I wish I had another figure that I frequently use here. But yes, absolutely have seen FND develop after traumatic hospitalization. Even after like a surgery that maybe had a prolonged anesthesia, that's something that I've seen. I've seen it after hospitalizations. I've seen it after extreme allergic reactions. Then I ask a lot of immune and inflammation-based questions. That's when we screen for mast cell activation syndrome as well, which is another complexity that we see with it's a common comorbid condition with EDS, with POTS. So those are some of the questions that I ask with those hospitalizations as well. I wish I had the figure that I typically will have to explain, but the understanding of FND is often that it's an accumulation of events or comorbid conditions that can contribute to the brain neuroplasticity kind of going awry. And a traumatic hospitalization, allergic reactions can definitely be one of the contributing factors. That's a great question. Okay, good question. Yes, how do you go about treating lack of proprioception? Love it. What specific PT interventions do you start with? So you should definitely come to our workshop, and we're going to talk about treatment. And you can see in the sensory pie, this can be done many different ways. Now, I always say you need a very good assessment first, right? So we need to know what is lacking proprioceptively. I never assume. I always want to assess. So assess it and then go into treatment. And some of my favorite things for proprioception are using an external focus to recalibrate joint proprioception. So the laser headlamp on the head, I like to put it on body parts and use a target for accuracy. Really, really helpful. Now, going back to the comorbid hypermobility that can occur, sometimes what is really helpful is bracing a hypermobile joint that is prone to dislocation. Sometimes it's actually compression and wrapping. We use a couple of different braces for that. Body braid is one of them, but heck, we might even use ACE wraps. We might use compression garments. So those are two things that we might specifically do in the case where proprioception is involved because of hypermobility. Awesome question. What does prodromal mean? Oh, great question. So in response to the last article, prodromal means that's not a good word for it, but before. So the question that they asked, and let me bring this back up again, is hypermobile Ehlers-Danlos syndrome a prodromal subtype of functional movement disorders, meaning it predated. And actually, it's kind of saying, is this the beginning stages of FND? That's my interpretation of the word. Actually, somebody can call me out if that's the wrong interpretation, which is why I don't exactly think it is. I don't think EDS is the beginning stages of FND. And I'll give you another example where we do see prodromal things. I think it's maybe a predisposing factor. But maybe that's also what these authors were saying for this word as well. In other disorders, so Parkinson's disease, for example, one of the things they've seen before diagnosis is a REM, a rapid eye movement, sleep behavior disorder. Loss of sense of smell was another prodromal symptom of Parkinson's disease. So that would be another example. Thank you for asking the question. Also said FND started after surgery. Not unusual. And in fact, in many neurologic disorders, surgery, while it's not the actual factor, the symptoms occur after. So this is something I commonly hear in Parkinson's disease, actually, is that they, I shouldn't say commonly. It's just, I've heard it enough where the person didn't really have clear symptoms, then they had surgery, and after surgery, their symptoms were more clear. Hey, surgery, anesthesia, it affects the brain. It's not that the person didn't have Parkinson's and then had it, and I think same with FND, didn't have it and then had it. It's just that it was the perfect accumulation of things and changes in the brain that that kind of clicked the switch in a way. Somebody else is asking about gastroparesis. Great question. This is something we also hear a lot. I'll stop sharing this for a moment. I should put some of these things on here. Gastroparesis is complicated. Could be many causes, but we do see this in dysautonomia because we could see a slowing down of your GI tract. And it can be something that we see with POTS or other forms of dysautonomia. We can also see it with FND. So that is something that we want to screen for. Somebody asked about outcome measures. We do a lot of screening measures for our programs, and one of them is called the Compass 31, and it looks at all those autonomic symptoms, and gastroparesis is one of them. So great question. Somebody else asked, is dystonia FND? Great question. So there is functional dystonia. There's also dystonia that's not functional. That's confusing, right? So if I were to make another pie chart, often what I will see with dystonia is I will actually see an idiopathic dystonia or a genetic dystonia or a task-specific dystonia, like runner's dystonia, or I'll see a cervical dystonia, and it's not functional. But the person might also have a functional neurologic disorder, meaning the dystonia itself, if it's invariable, meaning it doesn't have, it doesn't change with different environments, it doesn't change pattern, it's a very consistent pattern, that's an idiopathic dystonia. However, maybe there is a variable tremor associated with it, or maybe there is one component of the dystonia that is variable, and that variability is part of a functional neurologic disorder. So we got to test it, and the thing is, what's good for dystonia is good for functional neurologic disorders and vice versa. They're not one and the same, but there are some common mechanisms. Maybe you saw my post earlier this week where I mentioned the twisties, I mentioned the golfer's yips, I mentioned musician's dystonia. Common links to FND are mechanism. They're not all FND, or maybe there's components of them, but the mechanism, so sensory changes, motor control changes, all common in those pieces. Dissociation, which is common in twisties, for example. Somebody else asked, look at all these great questions. Is CRPS a prodromal subtype of FND? We're going to have a whole nother conversation on CRPS, because there are very interesting overlaps with CRPS and FND. And in fact, CRPS has often been classified as a subtype of FND. Again, similar mechanisms, commonalities, but distinct diagnostic criteria for CRPS. Another disorder that's like this is 3PD, persistent postural perceptual dizziness. It is considered a functional dizziness, and it also has its own distinct criteria. So there's many things under the umbrella of functional neurologic disorders. Yeah, I'm hearing a lot after surgery. So yes, this is something that we absolutely see. And do you do Botox? So I'm not a physician, I'm not a neurologist, so I don't do Botox. I don't administer it at all, but I work really closely with neurologists who do, and we collaborate. If particularly where I see Botox the most effective is in cervical dystonia. So I collaborate really closely with the movement disorder neurologist. Hey, I'm seeing this in this muscle. We might use EMG and might make suggestions. Great question. Do you associate FND with function in the basal ganglia? Great question. I wish I had another picture to show you here. It depends, but I don't image the brain, but I read the studies looking at loads of imaging in the brain, and the basal ganglia hasn't been a huge highlight in functional neurologic disorders, but other parts of the brain have. Right temporal parietal junction, supplementary motor areas, how these parts of the brain talk to each other. And even in Parkinson's, which is highly basal ganglia oriented, we know the connection issue is actually the bigger issue. How those parts of the brain talk to the frontal lobe, for example, are really, really important. So I think that we have a lot to learn in FND, and we're going to keep learning. Another great question here. What part of the pie chart would functional tics be under? Great question. So let me put this in here. Maybe I shouldn't have switched there, but when it comes to treatment, the treatment is based on the underlying issues. So we don't treat the functional tic, we treat the reason the person's having the functional tic, right? So that might be, and what I see the most in functional tics, sensory, autonomic, psychosocial pieces. And so this is why we have a team that treats all of those pieces. And you know what? The pieces are very individual for that person. One thing I would say is, again, very often, so I'm going to keep bringing up this diagnosis pie chart again, very often what we see is functional tics and other things. So functional tics and hypermobility, functional tics and autism, functional tics and dysautonomia. What we look for is the intersection of those diagnoses and what we might treat. And that is why I say then, regardless of its functional tics, well, certainly there are things that are more helpful for functional tics than functional paralysis. We want to go and assess the person individually and not chase the symptom, but get to the underlying either predisposing factor or the underlying piece for that person. Amazing questions. So I shared a couple of articles today on hypermobility and the connection with FND. I shared a little bit about dysautonomia as well. So I want to give you, if you're a clinician, I want to give you a couple of really great resources to go to. Let me start here. This was just a little capture that I got. Emily Rich is an OT who specializes in EDS, hypermobility, and POTS and dysautonomia. Our team, so we have a team of OTs, we have a team of PTs, we have psychologists, they all specialize in this as well, but we've learned a lot from Emily. And I just had to shout her out here. She's not a part of Reactive, but she has some awesome, she has a course on POTS. She shares a lot of great tips and tricks for things. So go give her a follow, and she's awesome. I'm also so very excited that she's going to come and mentor in our Brain Bites group for clinicians. We open our doors soon, and she's just so fabulous. I'm really, really excited to have her come. So go give her a follow. She's got great resources, and she's actually standing in this picture in front of the Ehlers-Danlos Society. A big shout out to this organization because they are phenomenal, and many of our therapists have done or are doing what are called EDS echo groups to further dive into EDS. They do so many great webinars and teachings and things through the Ehlers-Danlos Society. If you're a clinician working with hypermobility or wanting to learn more, I highly recommend it. So that is one resource I wanted to share with you. Another resource that our team has used a lot and really helped us refine some of what we're doing in dysautonomia. Let me bring it up here. This was a presentation at CSM this year. So in February of this year, emerging strategies for the physical therapist to identify and manage dysautonomia. Great group from Utah, and they had some really awesome suggestions in this presentation for assessment and treatment. And we use these a lot. We use them in our FND program, our concussion program, anywhere we see these overlapping conditions with POTS. So if you're a clinician, I highly recommend this session from CSM this year. And maybe I'll do a live session on all of the things that we learned about from that. Okay, there's lots of questions coming in. Functional dystonia with the twisties. Do you have more info I can find out on that? So what a great question. So let me stop sharing my screen here for a moment. So let me start. Somebody else asked, can you share a bit more about the twisties? Great. Okay, so the twisties is a phenomena in gymnasts, and it's actually, I was talking to somebody who was at a gym for gymnasts today, and it's like, this is really common. And it came out, I think, to the rest of the world because Simone Biles experienced this. And what it is gymnasts do these amazing twists and twirls and leaps and flips, and I'm clearly not a gymnast because I'm not using any of the proper names, but they do amazing things with their bodies. And the twisties is when they experience, in the midst of a twist, a total loss of contact with their body. And it's described like a block and a dissociation, and it can be very, very dangerous. Now, this type of block in a movement also occurs in other things. So golfers get it, baseball players get it. It's called the yips. And in gymnasts, actually somebody commented, and I was talking to another person today, it is temporary. And in golfers and in a lot of people, it's a temporary condition because they go right back to the basics and go back to relearning the movement again, because otherwise it's not safe to do. Now, there has been questions like, is that dystonia that occurs, midair with them? Is it a functional neurologic disorder? And actually, I went to the literature this week, found a lot of interesting things, but nothing to that effect. Some of the pieces looking at this look at it more as a disconnect. So there might be a sensory disconnect. I would suggest maybe also a vestibular piece, that depersonalization, derealization. We've talked about it before, like Alice in Wonderland syndrome. Could almost imagine that happening in the air, right? So there is not research on that, I will tell you, but it appears to be that there are some overlaps in mechanism between something like the twisties, dystonia, and functional neurologic disorders. So this person asked, do you have any more info I can find on that? I'm looking, and I will keep looking. I will tell you, I'm going to go live later this week, and there was this excellent article that highlighted these pieces and looking at the predictive brain. So it wasn't diagnosis specific, but it was really looking at mechanistically, how can, high anxiety and Olympic level meet actually kind of hijack the brain and cause this to happen. And it is possible, as the brain is set up to predict movement for us. So I'm going to talk about that article and the predictive brain later this week. And I think the understanding kind of the underlying pathophysiology is really helpful. Great question coming up. What's different about functional tics in autism versus stimming? Really great question. And honestly, I think you could absolutely have both. Stimming is something that if you're not familiar with it, that a person with autism might do, and it's actually a way of nervous system regulation. And helping the system regulate. What we see in functional tics is that the tic itself is actually a sign of dysregulation in the nervous system. A person might actually use stimming to help with a functional tic. And actually we might use that a lot. We use the sensory system a lot. Now, could it be possible that a person with autism actually develops functional tics because they're suppressing stimming? I think that's possible because their nervous system actually needs the stimulation, whatever that is, bouncing up on their toes, moving their hands, chewing down with their jaw. Their nervous system needs that for regulation. And if that's suppressed, it's quite possible to be expressed in different ways. So what a great and insightful question. I kind of want to dive in a little more on that actually and look some things up. We talked about the twisties. Let me get a couple more questions, then I'm just realizing the time. We've been going on for a while here. Okay, which medications do patient with functional tremors tend to respond to? Not always over the counter, as each case is, each case different in general. Great question. People aren't usually given medication for functional tremor, and I have not seen it respond to medication. Other types of tremor do respond to medication. So I should actually pause. Not even Parkinsonian tremor responds really well to medication. Essential tremor does, though. Now, to your point, and I don't prescribe medication, but if the functional tremor is due to another underlying issue that can be treated by medication, then absolutely, right? So let's say, for example, because I've seen this, maybe the functional tremor is actually part of a secondary response to POTS. Because when a person experiences dysautonomia, maybe their heart rate raises, their blood pressure drops, it actually would be really helpful to move the body and tremor to compensate for that. I'm not saying that's the underlying cause for all functional tremors, but it can be part of it, right? It could be an autonomic piece. Well, in that case, there might actually be medication to help with the POTS. There's medications that help with dysautonomia, and that should be treated. But otherwise, there's not known medications that help with functional tremors. Okay, for clients with FND that have a non-epileptic seizures, do you recommend them wearing life jackets if doing swimming or aquatic therapy? And what language do you use around this? Well, that is a brilliant question, and I don't know that I've thought about it. I haven't done aquatic therapy with them, but that's because I don't have a pool. I also have not seen that anybody's had a non-epileptic seizure in the pool, though it could happen. But hey, water, it's like fabulous sensory and proprioceptive information. And I think it can be really helpful in the person's journey in overcoming functional seizures. But I would say if there is a concern at all, that yeah, I wouldn't hesitate in having somebody use a life jacket if they're using that for therapy. Now, I will say, if I did have a pool, or let's say I went to a pool with a patient, or we go to the beach, if I'm with them, I feel 100% confident if they have a functional seizure with me present, that I don't need a life jacket, that I can help them. And I will tell you, even over ground, let's say we have people have seizures all the time in the clinic. We might not even use gait belts. I feel confident that I can be with the person and help them to the floor. And I'm not telling you not to wear a life jacket, because I think it's different in the pool, for sure. But one of the things that I think is really important is to reinforce safety when a person has functional seizure, and that they actually build that safety themselves, and that I am not heightening the concern and anxiety around their condition and symptoms. So if, for example, if they're walking and I'm constantly holding on to them because I'm worried, now I'm actually part of the problem, and I'm actually raising up the probability they're going to have a functional seizure. So that's my 2 cents on them. Always safety first, but I am going to build up that person's confidence and safety in themselves. One thing I might say is I might not do things in the pool, especially if that's like a fearful point for the person, until later, until they've built up their early recognition signs of the seizures, when they're having a lot less seizures. And then we might introduce the water for them so that they can have a really successful experience. What a great question. Cancer says, I work with autism children in special education aside from having dystonia. So this clinical aspect, it's so fascinating, right? It's really interesting. We work with a lot of teens and adults with autism as well. Body swelling in FND, absolutely. And again, here's the complexity. What is that related to? Often dysautonomia could be hypermobility related. It could be autoimmune related, but it could also be the FND. So we want to look at all of those pieces together. Great question. Oh my gosh, so many questions. This is awesome. Okay, I'm going to take a couple more, and then I think we need to call it a night. What about when a person has complete disassociation from their body? That's really tough, and describes it as feeling like they are possessed and can only be lucid but not have control from the paralysis of the movement. That is something that we can see in a functional neurologic disorder. We could also see that in dysautonomia. So those are both pieces we have to look for. And there we're really building up that person's ability to connect safely with their body. Really great question. I think this one, okay, have you come across literature where SIBO, small intestine bacterial overgrowth, is linked to functional tremors as an underlying cause? Have not seen that, would be interested, and I have seen many people with FND that also have SIBO. Or other GI related issues. So wouldn't be unheard of. We know the gut affects the brain. We know the brain affects the gut. It goes both ways. That would be really interesting to look into. What a great question. I think I learned more than you all from all of your questions. I feel just like, wow, thank you. Thank you. I think I had these articles, I had our pie charts, I shared Emily, and if you're a clinician, come join us to talk about these complexities next week. We're doing a workshop. We're going to talk about our framework. We're going to talk about 3 things you can do every single time that are going to help you with FND. So come join us. I can't wait to do this workshop next week. I'll go live again this week to keep answering your questions. So feel free to send questions my way. We're going to talk about the complexities of the brain and these disorders. And I just can't thank you enough. Thank you so much. I hope you have a great evening, and we'll see you next time.